Contemporary Proton Therapy Advancements 1. 2026 Advancements in Contemporary Proton Therapy. James L. Mahan. Department of Radiation Oncology Science Contemporary Proton Therapy Advancements 2. Abstract. Proton therapy has entered a pivotal era of clinical and technological maturation. Distinguished by the convergence of ultra-high dose rate flash delivery, online adaptive planning, and biologically informed linear energy transfer, LET, optimization. This paper surveys the most consequential advancements in contemporary proton therapy as reported in peer-reviewed literature through early 2026. Utilizing the physics of the Bragg peak where a monoenergetic proton beam deposits the majority of its energy at a predictable depth, described formally by the beta block stopping power equation, modern proton therapy systems now achieve sub-millimeter targeting with real-time anatomical correction. Flash proton therapy, defined by dose rates exceeding 40 Gy/s and sometimes surpassing 100 Gy/s, has progressed from preclinical animal models to first-in-human clinical trials, FAST-01 and FAST-02. Demonstrating equivalent tumor control with markedly reduced normal tissue toxicity. Pencil beam scanning, PBS, intensity modulated proton therapy, IMPT, and proton arc techniques have expanded the conformality achievable in complex anatomical regions. Online adaptive proton therapy, OAPT, workflows now enable plan modifications while the patient remains on the treatment couch, counteracting both interfractional and intrafractional anatomical variation. Global infrastructure has expanded to more than 120 operational proton centers by the end of 2024, with more than 450,000 cumulative patients treated. These developments collectively represent a new frontier in precision oncology, with implications for pediatric malignancies, head and neck carcinomas, thoracic tumors, and prostate cancer. Keywords: proton therapy, flash radiotherapy, Bragg peak, pencil beam scanning, linear energy transfer, adaptive radiation therapy, relative biological effectiveness. Contemporary proton therapy advancements 3. 2026 Advancements in Contemporary Proton Therapy. Introduction. The history of proton therapy is one of continuous refinement from Robert R. Wilson's foundational 1946 theoretical proposal on the clinical utility of fast protons, through the Berkeley Radiation Laboratory's first human treatments in the 1950s, and into the hospital-based clinical era inaugurated by the Loma Linda University Medical Center in 1990. Yet it is the period from 2024 through early 2026 that may ultimately be regarded as the most transformative. As of the end of 2024, there were more than 120 operational proton therapy centers worldwide, and more than 50 additional facilities under construction or in planning stages, with cumulative treated patients exceeding 450,000, Zhang et al., 2026. This rapid expansion has coincided with equally rapid technical innovation. Flash proton irradiation has advanced to prospective clinical trials, online adaptive workflows have reached clinical deployment, and a richer biophysical understanding of linear energy transfer, LET, and relative biological effectiveness, RBE, is reshaping treatment planning philosophy. The defining physical property of proton therapy remains the Bragg peak, the characteristic sharp maximum in the beta block stopping power curve at a depth determined by the incident kinetic energy of the proton beam. This property enables radiation oncologists to position the region of highest energy deposition within the tumor volume while allowing the beam to stop before reaching distal critical structures. The clinical consequences are measurable. Reduced integral dose to normal tissues, lower rates of secondary malignancy, and particularly for pediatric patients, preserved neurocognitive function and reduced endocrine morbidity. Do an ETAL, 2025. As these benefits gain rigorous clinical validation from randomized trials and large observational registries, the evidence base justifying proton therapy across a widening contemporary proton therapy advancements for range of indications has substantially strengthened. This paper organizes the current state of the field into 4 thematic sections. 1. Introduction to the foundational physics and the evolving clinical context. 2. Plan the strategic research agenda driving progress. 3. Purpose the clinical and population health goals that motivate ongoing investment. And 4. Practice the specific technical and clinical advances, including physics notations describing key dose delivery phenomena. A concluding synthesis draws these threads together and identifies priority questions for the next phase of inquiry. Plan, research agenda and strategic directions. The strategic research agenda in proton therapy for 2024 to 2026 has been shaped by several interacting imperatives: the need for higher quality comparative evidence against photon-based radiotherapy, the clinical translation of flash irradiation, the development of adaptive workflows capable of responding to intratreatment anatomical changes, and the optimization of biologically effective dose through LET-guided planning. The National Association for Proton Therapy, the Proton Collaborative Group, and the Particle Therapy Co-Operative Group, North America convened a joint research forum in September 2024 at the Johns Hopkins Bloomberg Center, bringing together thought leaders from every U.S. proton center to systematically identify priority research areas and needed trial designs. NAPTPCG TCOG-NA Forum, 2025. The forum identified head and neck cancers, pediatric malignancies, breast cancer, and prostate cancer as domains where clinical evidence from proton therapy is most urgently needed and where ongoing randomized trials are expected to be practice-defining. The randomized RADCOMP trial, NCT 02603341, completed accrual in March 2024 and is comparing proton beam therapy versus photon therapy for breast cancer requiring comprehensive regional nodal irradiation. Results from this landmark trial are anticipated to CONTEMPORARY proton therapy advancements 5. Influence standard of care decisions significantly. NAPTPCG TCOG-NA Forum, 2025. Similarly, the Prostate Advanced Radiation Technologies Investigation Quality of Life PARTIQOL trial, NCT 01617161, and the Prospective Comparative Study of Outcomes with Proton and Photon Radiation in Prostate Cancer, COMPARE, NCT 03561220, are expected to clarify optimal treatment strategies for prostate cancer. Pediatric oncology represents another critical planning priority, given that proton therapy offers dramatic reductions in integral dose to developing tissues. Randomized evidence in medulloblastoma, ependymoma, and rhabdomyosarcoma is being actively developed to replace the prior reliance on historical comparisons. From a physics and engineering standpoint, the research agenda has centered on achieving flash-compatible delivery without sacrificing spatial dose conformality. Conventional PBS proton systems deliver dose at rates on the order of 0.01 to 2 GY/s. Flash requires delivery at greater than or equal to 40 GY/s, and some proposed protocols target greater than 100 GY/s. Engineering challenges include beam current amplification, fast spot switching electronics, real-time dosimetry at ultra-high dose rates, and quality assurance frameworks that do not exist for conventional systems. Multi-institutional consensus statements on machine quality assurance for cyclotron-based flash PBS systems have now been published. Moerman et al., 2025. Establishing the technical prerequisites for the next generation of flash clinical trials. Purpose, clinical and population health objectives. The fundamental purpose of investing in proton therapy innovation is to improve the therapeutic ratio, maximizing tumor cell killing while minimizing radiation-induced injury to surrounding normal tissues. This principle, articulated in radiobiology as the differential in biologically effective dose, bed, between tumor and critical structures, is the thread connecting contemporary proton therapy advancements. 6. Every technical development described in this paper. The Bragg peak enables proton therapy to achieve substantially lower integral doses than photon-based IMRT or VMAT for most tumor geometries, and this physical advantage translates into measurable clinical benefit across multiple domains. In the pediatric population, the rationale for proton therapy is particularly compelling. Children face decades of life following curative therapy, and the long-term sequelae of photon-based craniospinal irradiation, including neurocognitive impairment, endocrinopathy, hearing loss, and elevated secondary malignancy risk, are well documented and devastating. Proton beam therapy research continues to yield encouraging outcomes in preserving cognitive function and reducing secondary cancer risks, particularly for patients aged 40 years and younger. NAPT. PCG TCOG NA Forum, 2025. Dose constraints for organs at risk, ORs, in pediatric proton therapy are increasingly well characterized through systematic reviews spanning a decade of clinical data, DUNETAL, 2025, though further validation remains needed, particularly for thoracic and abdominopelvic targets. For adult malignancies, the purpose of proton therapy increasingly encompasses not only OR sparing but also the immune sparing hypothesis, that the reduced dose path inherent to proton dose distributions may preserve circulating lymphocytes and immune organs, thereby augmenting anti-tumor immune responses. A smaller dose bath has been found to reduce exposure of circulating lymphocytes and the immune organs at risk, with emerging evidence suggesting the resulting immune sparing may improve oncological outcomes. Radhe, 2022. This immunological rationale intersects with the flash effect, where ultra-high dose rate irradiation appears to modulate the tumor immune microenvironment differently from conventional delivery. Flash proton therapy in preclinical non-small cell lung cancer models. Contemporary proton therapy advancements. 7. Demonstrated more efficient induction of cytotoxic CD8 plus T lymphocyte infiltration into tumors, while simultaneously reducing immunosuppressive regulatory T cell fractions. Shukla et al. 2023. At the population level, the purpose of expanding proton therapy infrastructure is to increase access to a modality that was previously confined to a handful of elite research institutions. The proliferation of compact, single-room proton systems with superconducting gantry designs has enabled regional hospitals in many countries to offer proton therapy at substantially reduced capital costs compared with earlier multi-room facilities. China has emerged as the primary driver of global proton center expansion, with more than 30 centers operational or under construction by the end of 2024, representing over half of all new worldwide projects. Zhang et al., 2026. Practice, technical advancements with physics notation. The Bragg peak and stopping power fundamentals. The physical foundation of proton therapy is the beta block equation, which describes the mean energy loss per unit path length, stopping power, of a charged particle traversing a medium. d/dx equals 4 pi ez superscript 2 nz slash m underscore ev superscript 2 ln 2 m underscore ev superscript 2 slash I ln 1 beta superscript 2 beta superscript 2. where E is the kinetic energy of the incident proton, x is the depth of penetration in the medium, E is the elementary charge, Z is the charge number of the projectile, Z equals 1 for protons. N is the atomic number density of the medium, Z is the atomic number of the absorber, M_E is the electron rest mass, V is the projectile velocity, I is the mean excitation energy of the medium. And beta equals V/c is the relativistic velocity ratio. The inverse square dependence on velocity means contemporary proton therapy advancements aid that as the proton decelerates, the stopping power increases nonlinearly, producing the characteristic Bragg peak before the proton comes to rest. In clinical practice, monoenergetic proton beams produce a pristine Bragg peak too. Narrow, typically 3 to 10 mm at the 80%, 20% distal falloff, to cover most tumor volumes. Spread out Bragg peaks, SOBPs, are created by superimposing beams of multiple energies. A fundamental pencil beam scanning, PBS, technique to produce a flat, extended dose plateau across the target depth. The SOBP dose distribution can be expressed as D_SOBP, Z, equals sigma WD underscore mono, Z, E, where D_SOBP is the total dose at depth Z, W is the weight, monitor unit weighting, assigned to the ITH energy layer, and D_mono, Z, E, is the depth dose distribution of a mono energetic proton beam of energy E. Modern IMPT optimization solves for the full set of spot weights WJK across all energy layers and lateral scanning positions to achieve the desired dose distribution while satisfying OR constraints. Relative biological effectiveness and linear energy transfer optimization. The biological effectiveness of proton irradiation is not constant along the beam path. The relative biological effectiveness, RBE, is defined as RBE equals D_ref/D_proton, where D_ref is the photon dose required to produce a given biological effect, and D_proton is the proton dose producing the same effect under identical conditions. Clinical proton therapy has historically employed a fixed generic RBE of 1.1 throughout the beam. Contemporary proton therapy advancements 9. Path a simplification increasingly recognized as inadequate. The actual RBE varies as a function of let, kev/μm, dose per fraction, tissue type, and biological endpoint, with RBE values in the distal Bragg peak region often exceeding 1.3 to 1.5 in tissue equivalent media. The clinical implementation of proton therapy is challenged by the oversimplification of RBE as a fixed value of 1.1, which does not account for the complex interplay between dose, let, and biological endpoints. Chen et al., 2025. Let guided treatment planning seeks to redistribute dose such that high let regions associated with greater biological effectiveness are positioned within the gross tumor volume, GTV, rather than in adjacent critical structures. Analytical let calculation models and Monte Carlo simulation frameworks have been developed and are undergoing clinical validation. The let_D, dose averaged let, metric is most commonly employed for plan evaluation. Let_D equals sigma D let/sigma D, where D is the dose contribution of the ITH particle track and let is its corresponding let value. Robust optimization for spot scanning proton therapy based on dose let volume constraints has demonstrated the feasibility of simultaneously satisfying physical dose objectives and biological let constraints. Chen et al., 2025, representing a significant advance toward biologically optimized proton treatment planning in head and neck cancer and other complex anatomical sites. Flash proton therapy, ultra-high dose rate delivery. Flash radiotherapy is defined by dose rates equal to or exceeding 40 GY/s orders of magnitude above the 0.01 to 2 GY/s of conventional delivery. The flash effect is the observation that such ultra-high dose rates produce equivalent tumor control while substantially reducing contemporary proton therapy advancements. 10. Normal tissue toxicity compared with conventional dose rates. The flash effect, defined as normal tissue sparing while maintaining tumor control with ultra-high dose rate irradiation, has been demonstrated preclinically in different tumors and tissues, although the biological mechanisms remain under active investigation. Moerman et al., 2025. Proposed mechanistic hypotheses include transient oxygen depletion, the oxygen depletion hypothesis, differential DNA damage kinetics, and immune microenvironment modulation. The dose rate for a PBS proton system delivering flash must satisfy _flash equals d _total / t _delivery greater than or equal to 40 GY/s, where d _total is the prescription dose and t _delivery is the total irradiation time. For the FAST-01 trial at Cincinnati Children's/UC Health Proton Therapy Center, the world's first prospective clinical trial of flash radiotherapy patients with painful extremity bone metastases received an 8 GY single fraction at a dose rate of 60 GY/s using the ProBeam system. Irradiation time was less than 1 second, Doherty et al., 2024. The mean time on table averaged approximately 15.7 minutes when positioning and imaging were included. The subsequent FAST-02 study, NCT 055240064, extended the approach to thoracic bone metastases, targeting sites including ribs, clavicle, scapula, and sternum, with FDA investigational device exemption approval and evaluation of cardiac and pulmonary or safety. From a planning standpoint, flash arc therapy, PFAT, has been proposed as a strategy that combines the conformality advantages of arc delivery with flash rate irradiation by spatially fractionating the dose to healthy tissue across multiple gantry angles, thereby achieving high dose rates at each individual spot while reducing total or exposure. Clinical translation of flash RT faces challenges in defining and delivering high dose rates in conformal CONTEMPORARY proton therapy advancements. 11. Geometries, and proton arc therapy offers a promising solution by leveraging arc delivery while addressing flash constraints through spatial fractionation. Smith et al., 2025. Simultaneous dose and dose rate optimization, STRO, algorithms are now being developed to co-optimize physical dose distributions and dose rate distributions in flash treatment planning, replacing the sequential approach of optimizing dose first and then evaluating achievable dose rates. Online adaptive proton therapy. Proton dose distributions are highly sensitive to anatomical changes because the position of the Bragg peak depends critically on the water equivalent path length, WEPL, of all tissues traversed by each beamlet. The WEPL is expressed as WEPL equals indefinite integral ρ_rel, s, ds, where L is the geometric path length, S is the position along the beam, and ρ_rel, S, is the relative stopping power of the tissue at position S, normalized to water. Patient weight changes, tumor regression, cavity filling, and positional variation during treatment collectively termed interfractional and intrafractional anatomical variations can shift the Bragg peak by centimeters relative to the planned position, potentially delivering high dose to a critical structure rather than the tumor. Online adaptive proton therapy, OAPT, addresses this problem by acquiring imaging, typically CBCT or MRI, while the patient is on the treatment couch and reoptimizing the treatment plan before delivery. First, OAPT workflows for daily plan adaptation that are effective. Against interfractional anatomical variations have reached clinical application, Gambetta et al. 2025, Near Real-Time Adaptive Proton Therapy, NAPT, which relies on online in vivo treatment. Verification to respond to intrafractional variations during delivery itself, represents the next contemporary proton therapy advancements. 12. Frontier. NAPT would be particularly transformative for thoraco-abdominal tumors that presently remain challenging due to the influence of respiratory motion on proton beam range. Clinical outcomes, comparative efficacy across anatomical sites. A 2026 nationwide analysis published in Neuro-Oncology Advances examined survival outcomes in spinal chondrosarcoma, comparing proton therapy versus photon-based modalities. In a cohort of 1,971 patients drawn from the National Cancer Database. Of patients receiving radiation, 343, 17.4%, received radiation treatment. Proton therapy demonstrated superior long-term survival compared with photon therapy, P70GY, and stereotactic body radiation therapy, further improving outcomes, Khalifa et al., 2026. This finding aligns with established radiobiological reasoning. The proximity of the spinal cord and adjacent vascular structures to chondrosarcoma target volumes makes the sparing afforded by proton Bragg peak physics particularly impactful. In prostate cancer, hypofractionated proton therapy delivering larger doses per fraction over fewer treatment sessions has emerged as a major clinical direction. Modern proton therapy for prostate cancer exploits the Bragg peak to achieve highly conformal dose distributions while minimizing radiation exposure to the rectum, bladder, and erectile neurovascular structures, Chabra et al., 2026. 5-year outcomes from the COMPARE trial and ongoing analyses from institutional registries are beginning to populate the evidence landscape, with PBS-delivered hypofractionated proton therapy demonstrating favorable toxicity profiles comparable to those observed in IMRT cohorts, with potential for superior GI and GU outcomes at equivalent tumor control rates. In head and neck oncology, dose constraints for organs at risk remain a critical area of ongoing research. A 2025 systematic review published in Precision Radiation Oncology Contemporary Proton Therapy Advancements 13 synthesized more than a decade of clinical evidence across 5 domains: adult CNS tumors, head and neck carcinomas, thoracic malignancies, abdominopelvic neoplasms, and pediatric cancers, and concluded that unlike photon radiotherapy, for which the Quantec consensus dose constraints are well established, standardized constraints for proton therapy require further validation. Duan et al., 2025. Let optimization in head and neck proton therapy has demonstrated the feasibility of improving normal tissue sparing in nervous structures, with RBE guided planning and let volume constraints showing dosimetric advantages over conventional proton planning approaches. Chen et al., 2025. Conclusion. The period from 2024 through early 2026 has witnessed unprecedented convergence of physical, biological, and clinical innovation in proton therapy. The Bragg peak, mathematically described by the beta block stopping power relationship, remains the foundational physical advantage that distinguishes proton therapy from photon-based radiotherapy, but the field has advanced far beyond exploiting this advantage alone. Flash proton delivery at dose rates exceeding 40 GY/s has moved from preclinical hypothesis to early-phase human trials, suggesting that the temporal dimension of dose delivery is a biological variable with profound clinical consequences. Online adaptive workflows have been operationalized to counteract the sensitivity of proton dose distributions to anatomical variation, and let optimized treatment Planning is moving toward clinical implementation in head and neck and other complex cases. Global proton therapy infrastructure has expanded dramatically, with over 120 centers worldwide and more than 450,000 patients treated cumulatively through 2024, Zhang et al. 2026, randomized clinical trial evidence from PARTIQOL, COMP-PAIR, RAD-COMP, and the MD Anderson oropharyngeal carcinoma trial is actively maturing and will provide the highest contemporary proton therapy advancements. 14. Quality comparative evidence to date. Dose-constrained standardization for ORs across tumor sites remains an area of active synthesis and consensus building, Duan et al., 2025. The integration of immuno-oncology insights with proton therapy dosimetry, particularly the hypothesis that reduced lymphocyte exposure may enhance anti-tumor immunity, opens new avenues for combining proton therapy with immunotherapy regimens. In summary, contemporary proton therapy stands at the threshold of its most evidence-rich and technically sophisticated era. The convergence of flash delivery, adaptive planning, biologically informed optimization, and global clinical data generation positions proton therapy not merely as a dosimetric tool but as a platform for precision oncology. Future work must prioritize rigorous randomized evidence generation, development of real-time adaptive and in vivo verification capabilities, and equitable expansion of access to patient populations worldwide who stand to benefit most from this technology. References: Chen, J, Yang, Y, Feng, H, Liu, C, Zhang, L, Holmes, J. M, Liu, Z, Lin, H, Liu, T, Simone. CB2, Li, N.Y., Frank, S.J., Ma, D.J., Patel, S.M., and Liu, W., 2025. Enabling clinical use of linear energy transfer in proton therapy for head and neck cancer, a review of implications for treatment planning and adverse events study. Visualized. Cancer Medicine, 6, 3. https://doi.org/10.1051/vcm/20250001. Chabra, A.M., Mehta, K.J., and Simone, CB2. 2026, Modern Proton Therapy in Prostate Cancer, Precision in Practice. Frontiers in Oncology, 16, Article 177-5107. https://doi.org/10.3389/fon.2026.1775107 Contemporary Proton Therapy Advancements. 15. Doherty, E., Zhang, Y., Xiao, Z, Moscha, A. E., Cert Orito, M, Wu, J, ETAL, 2024. Flash radiotherapy for the treatment of symptomatic bone metastases in the thorax, FAST-02. Protocol for a prospective study of a novel radiotherapy approach. Radiation Oncology. 1934. https://doi.org/10.1086/13014-024-02419-4. Duin, S, ETAL, 2025. Clinical Advances and Challenges in Dose Constraints for Organs at Risk in Proton Therapy, a systematic review of the last decade's literature. Precision Radiation. Oncology, 9, 210-220. https://doi.org/10.1002/pro6.70020. Gambetta, M, Stutzer, K, and Richter, C, 2025. Current status and upcoming developments for online adaptive proton therapy enabling a closed feedback loop for near real-time Adaptation. Frontiers in Oncology, 15, Article 166-0605. https://doi.org/10.3389/fon.2025.1660605. Khalifa, J. M., Ahmed, A. K., Weinberg, J., Foster, C., Theodore, N., and Lubelski, D., 2026. Impact of proton versus photon radiotherapy on overall survival in the management of spinal chondrosarcoma and mortality risk prediction, a nationwide analysis. Neuro-oncology. Advances, 8, 1, VDAF 240. https://doi.org/10.1093/NOAA-JNL/VDAF 240. Moerman, A. M., ETAL, 2025. Requirements and Study Design for the Next Proton Flash. Clinical Trials, an International Multidisciplinary Delphi Consensus. International Journal of Radiation Oncology, Biology, Physics. https://doi.org/10.1016/j.ijrob.2025.03.047 Contemporary Proton Therapy Advancements 16. National Association for Proton Therapy, Proton Collaborative Group, and Particle Therapy Co. Operative Group, North America. 2025, Proceedings of the 2024 NAPT, PCG, and TCOG-NA Proton Therapy Research Forum, Refining Particle Therapy Trial Design and Identifying High-Need Areas for Continued Investigation. International Journal of Radiation Oncology, Biology, Physics. https://doi.org/10.1016/j.ijrob.2025.045201. Radhi, M., 2022. A Review of Proton Therapy, Current Status and Future Directions. Precision. Radiation Oncology, 6, 2, 164-176. https://doi.org/10.1002/pro6.1159. Shukla, S., Saha, T., Rama, N., Acharya, A., L.E., T., Bien, F., ETAL, 2023. Ultra-high dose rate. Proton flash improves tumor control. Radiotherapy and Oncology, 186, 109,741. https://doi.org/10.1016/j.radon.2023.109741. Smith, B.R., Flynn, R.T., Gutierrez, A.N., and Heyer, D.E., 2025. Range compensated pencil. Beam scanning proton arc therapy, a feasibility study. Communications engineering, 4. 139 https://doi.org/10.1038/S44172-025-00460-Z. Zhang, Y, Yang, X, 10, Y, Guo, Z, Wang, L, Zhu, H, Jing, S, Ma, Y, and Ho, Q, 2026. Advances in Proton Therapy Technology and Global Clinical Applications. Frontiers in Oncology, 16, Article 171-8677. https://doi.org/10.3389/fon.2026.1718677